like to call upon Dr. Ramamurthy, sir, for his talk on CLEAR.
Thank you, Rohit, and sorry for the slight disruption. I'm going to be talking about the CLEAR platform. One of the things the reason I bought the Z8 was that multiple applications that it has is able to create flaps. It's able to, I think CLEX is the right term, that is keratorefractive surgery by lens extraction. And we have CLEAR, we have SMILE, we have smart laser, or silk, etc. I think by definition it should be CLEX because all these procedures come under that. Is able to create arcuate incisions, take care of creating channels for intracorneal segments, pockets for corneal inlays, able to perform corneal deep lamellar as well as lamellar cataracts, lamellar corneal surgery. And then of course it has the capability to do LRCS also. It's an all-in-one platform, and also the fact that it has a very small footprint of 3 into 2 feet, and it can be mobilized in a vehicle. We actually use it in 6 different centers on 6 different days, spread over a distance of 500 kilometers. So it's an enabling technology. I have been using the SMILE technology, the Visumax, for almost 12 years now. Extremely happy with that. And the reason I went for this was that we thought this is one instrument which should take care of multiple requirements in many places. The CLEAR actually stands for corneal lenticle extraction for advanced refractive correction. So what are the unique features of this? But I thought it's a unique feature, but as I hear, nowadays every manufacturer has moved on to using lower and lower energy, and this uses less than 100 nanojoules of energy. The small spot size of less than 2 microns, extremely high variable repetition rate of 1 to 10 megahertz. When it comes to refractive procedures like the CLEAR and the flaps, it fires at the rate of 10 megahertz. But when it comes to cataract surgery, for fragmentation, arcuates, incision, it's 2 megahertz. For capsulotomy, it's 1 megahertz. Depending on the kind of tissue that needs dissection, the frequency is also adjusted. And one of the unique features of this is that many of the platforms talk about the distance between these 2 spots. They're touching each other. But here, the spots actually overlap each other, because of which the resection of the tissue bridges is much better. And I also experienced that the removal of the lenticule is extremely easy. And this is also supposed to add to the flap thickness, precision, and predictability. The other important difference from the other platforms is most of the others have a microscope attached to it, and the distance of the optical chamber from where the laser chamber, which is to the eye, is quite significant. In the other hand, this is handheld, almost brought in contact with the eye, because of which there is a very short working distance, and this adds to the precision as well as the ability to use lower energy and a smaller spot size. And other factors which is unique about this equipment is it takes into consideration the Q value at 8 millimeter. And once you feed this in, as has been done in this case, then the idea is to maintain the Q value at the preoperative level. Once it does that, it's supposed to reduce the effect on the effective optic zone. Usually when you feed in 6.5 millimeters, with most excimer platforms or even lenticule platforms, you get about a 0.8 to 1 millimeter reduction. Here just about 0.5 millimeters. And just in case you do not feed in the Q value, it assumes a Q value of 0.26 and the cornea is left behind as such. The keratometry values are also fed into the machine, and it is said that the nomogram is titrated in such a way that the initial keratometry values are also taken into consideration. There are 2 levels of marking that is done. One is for cyclotorsion compensation. This is done under the slit lamp in the preoperative area, where if you get a straight line like this at the 3 o'clock and 9 o'clock meridian, the machine automatically recognizes that it's automatic rotation, and there is a cyclotorsion compensation that happens. But in case you get a smudge spot like this, then the machine does not function, and you have to manually rotate so as to compensate for the cyclotorsion. The other next compensation is for centering the treatment on the visual axis. You already have through spots on the 3 and 9 o'clock axis. We again mark at the 6 o'clock axis and ensure that the horizontal and the vertical line cross over the the first Purkinje image, which essentially corresponds to the visual axis. And once you do this, there is a compensation both for cyclotorsion as well as the treatment is centered on the visual axis. It is said that in the future this will be integrated with the Galilei topographer and the need for manually compensating this would not be there. There are two venting incisions in this, one anterior to the lenticule, one posterior to the lenticule, evacuating the gas generated in a more efficient manner. Again, you have a choice of creating two incisions, one going anterior to the lenticule, one going posterior to the lenticule. I myself, because of my significant experience with SMILE, stick on to one single incision at 90 degrees and it seems to work quite well. But then for beginners, it seems to be a significant advantage. And there is a range of power correction is up to minus 12.5 diopters, though I do not go beyond minus 8 diopters. For cylinder, it's up to about 2.5 to 3 diopters. And the optical zone diameter, usually we keep at 6.5 millimeters, which gives an effective optical zone correction of about 6 millimeters. The cap thickness, we usually leave it at around 120 microns, though occasionally we drop it down to 110 microns. A short video of the procedure per se, and as you can see, the Q and the K values have been fed in. It's a significant myopic astigmatism that we are going to be treating, and basically the treatment is, you can center the treatment, and it's a 6.5 millimeter optic zone that I'm going to use with a 120 micron cap thickness, and then subsequently you place the PI onto the eye. Basically, you can do a single step or a double step docking. I usually prefer a double step docking. And then the handheld instrument is brought onto the eye and the docking happens. You can see this ring. It's a fairly simple procedure, a little different from what you're used to, but then it's easily, once you do a few cases, you can easily master this. And then you switch on activate the suction, and it's a fairly strong suction. It's a planar suction, and we have not had a single suction loss in spite of the fact that it takes almost 35 seconds for the treatment to be completed. And essentially, there is a laser flow from the periphery to the central point, both for the lenticular cut as well as for the planar cut anteriorly, and that's the laser. And you have ultimately you have an incision being made, in which in my case is usually about 2.5 to 3 millimeters. This gives an excellent access to the lenticule per se. As I mentioned, this is it takes a little longer time, takes about 35 seconds, but the suction loss is not there. One good thing about this laser is that the ease with which you are able to dissect out the lenticules, maybe because of the overlapping spots. I find that there is hardly any dissection that's needed in this, and you can see that both anteriorly and posteriorly you can go ahead and separate out the lenticule, and usually no dissection is necessary. The lenticule just flows out once you have separated it, and then it's been recommended that we do a good smoothing of the anterior corneal surface so as to take care of the Bowman's wrinkles. They also recommend that a good interface wash has to be done. These were two procedures that we are not doing when we are sticking on to SMILE. We have done more than 1,000 eyes so far in 6 different centers, but initially when we had it in our principal center doing 200 eyes, usual run-of-the-mill myopic eyes were about average power being about minus 4 diopters. The post-operative uncorrected distant visual acuity was 20/20 or better in 89% of the eyes, and most significantly what bothered us was that 6.5% of them lost one or more line of corrected distant visual acuity, and especially on the first post-operative day, the happiness quotient of these patients was not as good as what we had experienced earlier. But now that we have customized our power settings, energy settings, we find that the results are much better, much tighter, and even across different surgical single hands, it works quite well. And showed no significant undercorrection even for high refractive errors. You can see the tightness of the spots over here, the scattergram, which shows an extremely good results. We corrected up to about 2.5 diopters of astigmatism in initial study. Again, this was taken care of quite adequately. And in the 6-month follow-up, the results that we achieved was also quite stable. As I already mentioned, there was no case of suction loss or aborted treatment, maybe because the strong suction, in spite of the treatment being quite significant. And there was no case of remnant lenticule or lenticule tear because the lenticle separation was so good. So basically, to summarize, it's I think Clear is another significant platform. It's always good to have choices. That's how we progress and are able to offer better and better things to our patients. The day one post-operative outcomes improved after energy optimization, lower complication rate because of suction loss, easy lenticule removal. I think the selling point for this platform is the true mobility and multiple applications, which allows advanced technologies to be delivered in a cost-effective manner at multiple centers. Thank you so much for your kind attention.
Thank you, sir. One very interesting things emerging from all the new lenticule procedures is the way they're trying to change the shape of the lenticule itself, like how we started off with the dimension of topo-guided treatment. And, one new thing, what you said was you can use the Q value and that would change. So all this platform, I think all the whether it's Smile, Etos, Silk, all of them and Zimmer are looking into that direction, which is very, very promising. Thank you, sir. I'd like to call upon Dr. Jodh Mehta to be here to co-chair this session and request Madam for her first talk on retained lenticules. Any questions for Dr. Ramamurthy? Ma'am will take a few minutes to get ready. So when you take these machines to different places, these, do you feel that if you take this machine, say 200 kilometers away, will that optics and your whole dissection, your spot and energies change when you're taken after 200 kilometers and then you start the procedures? Actually, or you have to recalibrate every time you take it?
Actually, this was a major concern that we had as regards outcomes. And when it comes to LRCs as well as flaps, because the precision is less of an issue, I think the results are quite good. But where Clear, it's the size of the lenticule which matters, the dimensions of it. It was a great concern. What we do is to do the treatment in the morning, transport it in the afternoon. There's a biomedical engineer traveling with the machine, and there's a calibration that is done. And once in a while, there is a slight tweaking of the mirrors that's needed. But most often, so far, it's just about 6 months and it's working.